In India, too many women and infants die from causes that are both preventable and easily treatable. Evidence points to the critical importance of ensuring high-quality care during labor, delivery, and immediate postpartum and newborn period to save maternal and newborn lives. The ability of providers to manage normal deliveries according to best practice guidelines results in correct diagnosis, stabilization, management, and timely referral of maternal and newborn complications. The government of Karnataka has prioritized improving maternal, neonatal, and child health services at 24/7 primary health centers to increase access to institutional deliveries in rural areas. The Sukshema project, funded by Bill and Melinda Gates Foundation, is focused on reducing maternal and newborn mortality in 8 high-priority districts in northern Karnataka. As one of its core strategies, the project developed an on-site mentoring program to support primary health centers to deliver critical maternal and newborn care services. It integrates clinical mentoring with facility-based quality improvement processes. On-site mentoring program is founded on 3 quality improvement principles: clients and providers' rights, self-assessment, and teamwork. The project employs a cadre of full-time nurse mentors. These mentors were given a comprehensive 5-week training at St. John's Medical College and Hospital to build mentoring and communication skills and clinical and system-level problem-solving skills. The Sukshema project developed several tools and techniques for improving quality that mentors use with PHC staff. The self-assessment checklists help PHC staff identify any gaps in providing quality care. Detailed case sheets reinforce skilled birth attendant guidelines and provide guidance on how to manage and refer maternal and newborn complications. The case sheets are a job aid for staff nurses and a very effective teaching tool for mentors to impart knowledge to staff nurses. Case sheets can also be used as a data source to track whether cases were managed according to guidelines. Each mentor is also equipped with a pelvic and newborn model and other teaching materials that she uses during her PHC visits. Each mentor is responsible for mentoring 6 to 8 primary health centers. These nurse mentors visit their designated PHCs for 3 days, once in every 2 months. So, what exactly does a mentoring visit look like? First, the mentor prepares for the visit to her PHC by reviewing PHC MNCH related data. The first mentoring visit provides an opportunity for the mentor to establish rapport with the PHC staff and to lead the initial team meeting. The mentor facilitates the process of self-assessment by the PHC staff, and staff fills the self-assessment tools. The mentor guides them through a process of problem solving that results in staff developing their PHC-specific action plans for implementation. Mentors spend much of their time with the staff nurses teaching about clinical topics. Mentors often demonstrate skills, and nurses perform written demonstrations. This ability of nurses to practice skills increases their competency. Mentors have taught about diagnosing prolonged and obstructed labor by instructing nurses on how to use a partograph. One common newborn complication is birth asphyxia, so mentors focus on teaching newborn resuscitation through demonstration and hands-on practice. Mentors use every opportunity for bedside mentoring, assisting nurses in the labor and postnatal wards and advising them on needed examination and counseling. Maintaining an infection-free labor ward is crucial to minimize risks of sepsis. Mentors teach nurses about proper disinfection and sterilization using chlorine solution as per government guidelines. On-site mentoring implementation is managed by the Quality Improvement Team of KHPT that is staffed by 2 technical managers, a deputy director and a director. The district-level implementation is supervised by the district program specialist who is from public health background and is trained in QI principles and approaches. Ongoing clinical support is provided by hand-holding visits by a team of obstetrician, pediatrician and senior nursing staff from St. John's Medical College and Hospital at regular intervals. Regular review meetings with the mentors are held by the district program specialists that provide a platform for the mentors to see the performance and improvements in their PHCs. Data of the PHCs are reviewed and strategies identified to further improve services. Zonal level meetings are also conducted at the end of every round of mentoring to facilitate cross-learning between districts and mentors that are supported by central level staff. PHC staff at all levels are able to point out tangible improvements in their PHCs since the mentoring program began.
ನಮ್ಗೆ ಡೆಲಿವರಿ ಮಾಡೋಕ್ಕೆ ಭಾಳ ಭಯ ಆಗ್ತಾ ಇತ್ತು ಸರ್. ಮಾಡಬೇಕಾದ್ರೆ ಏನು ಮಾಡಬೇಕು ಅಂತ ಅಷ್ಟು ಗೊತ್ತೇ ಇರಲಿಲ್ಲ. ಎಮರ್ಜೆನ್ಸಿ ಡ್ರಗ್ಸ್ ಆಗಲಿ ಯಾವ ರೀತಿ ಮ್ಯಾನೇಜ್ ಮಾಡಬೇಕಂತ ನಮ್ಗೆ ಗೊತ್ತಿರಲಿಲ್ಲ. ಮತ್ತು ಈ ಮೇಡಮ್ ಬಂದಮೇಲೆ ಎಲ್ಲ ತಿಳಿಸಿ ಹೇಳಿದರು ಸರ್. ಮತ್ತು ಪಾಟೋಗ್ರಾಫ್ ಹಾಕೋದು ಗೊತ್ತಿರಲಿಲ್ಲ ಸರ್. ಪಾಟೋಗ್ರಾಫ್ ಹಾಕಿ ಅದರಿಂದ ನಾವು ಯಾವ ಟೈಮಿಗೆ ಆಗುತ್ತೆ ಅಂತಲೂ ನಾವು ಪೇಷಂಟ್ಸಿಗೆ ಹೇಳಕ್ಕೆ ಸಾಧ್ಯ ಆಗಿದೆ ಸರ್.
ಮೆಂಟ್ರಿಂಗ್ ವಿಸಿಟ್ ಆದಮೇಲೆ ನಾವು ಏನೇನು ಚೇಂಜಸ್ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ ಅಂದಮೇಲೆ ಇದು ಬೇಬಿ ಕಾರ್ನರ್ ಸಪ್ರೇಟ್ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ. ಆಮೇಲೆ ಬೇಬಿಗೆ ಏನೇನು ಅವಶ್ಯಕತೆ ಇರ್ತದೆ ಅಂದ್ಬಿಟ್ಟು ಇಲ್ಲೊಂದು ಚೆಕ್ ಲಿಸ್ಟ್ ಹಾಕಿದ್ದೀವಿ ನಾವು. ರೇಡಿಯಂಟ್ ವಾರ್ಮರ್, ಬೇಬಿ ಟಾವೆಲ್ಸ್ ಈ ಥರ ಅದನ್ನು ರುಟೀನಾಗಿ ಚೆಕ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಮೆಂಟ್ರಿಂಗ್ ವಿಸಿಟ್ ಆದಮೇಲೆ ಮದರ್ ಕಾರ್ನರ್ ಮಾಡಿ ಆಮೇಲೆ ಇದು ಕೇಶಿಟ್ಸ್ ಇಲ್ಲೇ ಇಟ್ಕೊಂಡು ಕೇಶಿಟ್ಸ್ ಪ್ರಕಾರ ನಾವು ಅಬ್ಸರ್ವೇಷನ್ ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ಟು ಇದನ್ನು ಮೇಂಟೆನೆನ್ಸ್ ಮಾಡಿ ಇದರಲ್ಲೆಲ್ಲೂ ಚೇಂಜಸ್ ಮಾಡಿದ್ದೀವಿ. ಇಲ್ಲಿ ಒಂದು ಚಾರ್ಟ್ ಹಾಕಿದ್ದೀವಿ ನಾವು. ಈ ಚಾರ್ಟ್ ಪ್ರಕಾರನ ಎಲ್ಲ ಕಿಟ್ಸ್ ರೆಡಿ ಮಾಡಿ ಇಟ್ಟಿದ್ದೀವಿ. PPH ಕಿಟ್, ಎಕ್ಲೆಂಪ್ಸಿಯಾ ಕಿಟ್, emergency drugs kit.
A lot of improvements have happened. The staff nurses are able to find out the complications of the particularly deliveries, that is as good as obstetric portion of the gynecology. They have been categorized into A, B, C, D, E, F, G, which is the complication, what is the complication, how to find out the complication, how early they have to refer the cases, what cases they have to keep in the PSC they can deliver, or they will not be able to do such, which are the high risk patients they have to refer.
Complications can be handled, can be identified, can be handled there, and referring the patient in time to the next level. The deaths due to infant deaths due to birth asphyxia is up to 30%. The commonest reason is they were not following the pantograph. So they were not referring the patients to the next level, at the required time. This pantograph is definitely helping them.
The program, after a year of intervention in the PHCs, reviewed the progress and data generated at the PHCs. The results show that while knowledge and skills of nurses in all PHCs increased over the study period, nurses in the intervention PHCs reported the highest knowledge gains on all measures. Nurses that were mentored were more likely to correctly identify all steps of active management of third stage labor, know the 3 signs for correctly identifying and diagnosing eclampsia, know how to correctly perform bag and mask resuscitation. All mentored PHCs had improved supply of drugs in the labor room as well as lab services. Referent practices were more effective and timely in mentored PHCs. Routine monitoring has shown that case sheet usage has gone up and higher number of mothers and newborns are sent home healthy. The mentoring program is proving to be an effective intervention to improve quality of maternal and newborn services in primary health centers. If scaled up to other PHCs or even higher level facilities, the mentoring program can be an important contributor to reducing maternal and newborn mortality.